Behaviors, a review. Okay. Can you hear me okay? Is it too loud or? It's great? Okay. I just came today, so if you don't mind, before I get started, if you could just go around the room and tell me your field. And I caught Singapore, Switzerland, and Boston, but that would be great. Then I would have some background on what your field of training is. Mine's child psychiatry. Should I pick on somebody?
School psychology.
School psychology. Okay.
Nothing to do with psychology and plastic surgery.
I could have guessed that one, huh? Okay. Well, welcome. We're a nice bunch, aren't we?
I just like operating in children. That's fine.
I'm glad you do. Yes. Okay. Melbourne. Oh. Are you staying at my hotel? Did I run into you in the elevator? Yes. Yes. Okay. No such thing. You're talking to mental health professionals.
I'm a clinical geneticist and I'm from Scotland, but I'm here as president of the International Federation for Spine, Britain and Hippocampus. So some of our young people have got learning difficulties.
Wow. Fantastic. Okay. Okay, and if I'm also born in India, so if you tell me where, it'd be very exciting to know. Okay. All right. Okay, and where? And in Boston now, or? Okay, that's my neighboring. I'm from St. Louis, Missouri. Well, I live there now. I'm not really from there. Okay, very fantastic. Do you happen to know Leslie Halvershorn? No, youngin. Oh, all my friends are older, I guess. Okay. Okay. And do you have a specific niche?
Not really. Well, my department is largely doing research on mental health policy.
Ah, fantastic.
But we also do other
Okay.
psychological.
Okay. Oh, look at this service. I love this. People are so warm here. Thank you. All right.
I'm also from Singapore, Institute of Mental Health, senior research officer, mainly doing the population-based surveys, mental health policy-related projects. Plus, we also do clinical studies and validating instruments along the patient population. So, different projects we are doing it in departments.
Fantastic. So public health, from a public health perspective in Singapore.
Yeah.
Okay, fantastic.
So I'm from Germany, but living in Switzerland. I'm doing my PhD in clinical psychology, and I'm a psychotherapist.
Fantastic. Okay.
I'm from South Africa. I'm working in the University of Venda as a lecturer in public psychology.
Fantastic. Okay, and that's everybody? Nobody snuck in? Okay, great. Well, no one looks jet lagged, so this is great. And you've come from far, so I have no excuses. I was going to say I'm jet lagged, so if I screw up, then, you know. But so I'm Dr. Tandon, and you can call me Minnie. I tend to present very casually. Probably you'll see why, because my favorite age group is 4, 5, 6-year-olds. And so I thought it would be interesting to share with you some of my experiences as a child psychiatrist. I'm on faculty at Washington University School of Medicine in St. Louis, and I'm responsible for training the child psychiatry fellows in how to assess, treat, and diagnose the real young children, especially with the growth of autism and incidence of autism. We're having to start earlier and earlier. So what is the role of a physician, child psychiatrist in this kind of comprehensive assessment? And we've already touched on this in multiple ways, but we'll get into this topic. So I'm not going to just define ADHD today. It's going to be really specific to the younger kids, the data on the younger kids with ADHD, because I think most of us who've seen it kind of understand how ADHD works. So you're already halfway through the slides. Okay. Okay, so I'm supposed to say, so faculty, we always have to say, I have no disclosures, no stock equity. In fact, I owe a lot of medical student loans. I don't know how it is in the rest of the world, but I'm still paying those. So I don't have any disclosures. I am grant funded by the American Academy of Child and Adolescent Psychiatry, and also in combination with the National Institute on Drug Abuse. They jointly fund my research. And I currently have a copyright that might be a conflict on a children's book on mental health. And again, this I'll talk to you about it in a minute, but it speaks to the stigma and me having to explain to every kid over and over what it is to come to a child psychiatrist. So we decided to make a book. Okay, so what I'm going to go through today then is the background and prevalence of ADHD, oppositional defiant disorder, and conduct disorder. I'm sure you guys are all familiar with these diagnoses. Just let me know if you're not. Then the non-pharmacologic interventions, because you're going to say, well, Minnie, you see 3, 4, and 5-year-olds, so certainly you're not going to get up here and talk about psychotropics, are you? So first we're going to focus on the non-pharmacologic interventions, and after that, then when we get to that point, pharmacologic interventions and what has been evidenced, if anything, in this young age. So we'll cover behavioral parent training, parent-child interaction therapy. How many of you are familiar with either of those? How many of you see on a regular basis kids that are 6 and under? Okay. They're probably going to be coming your way. We're learning our field is really shifting, that we have to start earlier to capture language and other sort of, we really have to shift earlier so that people have to be very comfortable. And even our trainees at the university where I work, at first they come in, and their title will be child psychiatrist, but they come in and see a 3-year-old and they don't know what to do. So if we're not comfortable, then who will be with these young kids? So we'll cover those, and then we'll cover basic pharmacologic interventions that have some evidence in 6 and under. And am I speaking too fast? Is everybody okay? It feels from here that it's going in and out, or is that just me up here?
I just said feeling I had.
Okay.
It's, for us, it's normal.
Okay. Okay, now this I wrote because I don't have experience with the Greece mental health system, and so I thought this is what happens when someone is this age group and comes to see me in the clinic, in the specialty clinic. This is what we hear, and this is not really too much of an exaggeration. A 4-year-old presents with mom after he was kicked out of 3 daycares. Mom's chief complaint is, I can't keep a job because I have nowhere to take this person when I work. Child hits other children impulsively. He resists limits by teacher, he or she, parents, others. Forgets backpack all the time. Runs off at circle time. Circle time is a very common thing in preschool ages. That's where they sit together, do story time. You're asked to sit in a circle and pay attention. And while this sounds like a joke to older psychiatrists, it's what their work is at that age, is that how do you gain from your environment if you can't sit, right? So this is very common presentation. It's not always true, but of course often true, that history of in utero cigarette and possibly alcohol exposure is present. ADHD, you'll learn, and if you don't already know, it's highly heritable. And so it's not surprising that mom will say, it wasn't trendy to diagnose when I was little, but I have ADHD, and it just took me a long time to realize it's very genetic. So sometimes you'll get a maternal history or paternal history, either one, of ADHD. He hardly gets tired. It's like he's wired all the time. And sometimes there's no other medical concerns whatsoever. Okay. Okay, so you asked me, why do I waste my time with studying preschool ADHD? Well, in general, we think that 2 to 9% in pediatric clinic samples have ADHD. So it's not really small. This was even in a study that had not an epi sample, but in a pediatric clinical sample. We're going to pick on boys, but three times more prevalent in boys than girls. Preschoolers with ADHD show key deficits in executive functions, and of course there's a number of researchers that are studying this age group. And again, I think I'm speaking to people that already know this, but basically executive function would be summarized generally as top-down processing of cognition towards goals, inhibition, working memory, changing gears, so to speak. So what happens when you have to see a 3, 4, 5, 6-year-old, and what do we say is a comprehensive assessment? So first of all, not everyone will be in a situation where you're allowed to see a child to assess them in multiple time points. And we think this is highly critical in the ideal way to diagnose a young kid. Because you see a kid once and they have a headache, or they just had a soda, or they just had a chocolate, and they look very different than the next time you see them. And you don't want to go mislabeling a young child. So the idea is to have an optimal comprehensive assessment that includes multiple visits. So in our clinic, what we do is we have it set up so that there are 4 visits. Each visit is an hour, and it happens each week. And each time, the child does not come the first and last visits, because you're just giving history, or you're just comprehensively telling the diagnosis to the family. The second one is with one caregiver, and the third visit is with a different caregiver. That way you have multiple informants, multiple time points, and you have enough time so that when you give out forms and measures, that it comes back to your office before the diagnosis is made. So you get the objective, subjective. You do this all in a 2-way mirrored room so that the child can act as he or she would, as naturally as you can do it, so that you're the clinician watching behind the mirror. They can't see you, but they're playing like they would with mom in a room with a given set of toys. And that's what we think is relatively comprehensive. Now, this was not me that designed this, but my mentor helped me to design a clinic for myself when I finished. I don't know what the favored measures here, but I think that as long as you're using an objective validated measure for a specific age group, whether that's Vanderbilt or the Connors for this age group, that's good, because you need to have a combination. There's a lot of literature that suggests that parents may underreport, overreport, teachers may have a gain, the students may have a gain, the kid might be looking different. So you really want to be comprehensive, and that includes multiple informants always in this age. CBCL, I'm not sure how favored that is here, but Child Behavior Checklist by Achenbach. Some people call it the Achenbachs. There is a version that goes all the way down to age 1.5. That's also got a whole domain on attention problems that we use often in the clinic to stay comprehensive. Remember to ask family history, because again, it's highly heritable, and it can help you sort of understand that there may be some high risk for ADHD. And please don't forget to ask about exposures. We know that there is a higher risk of ADHD with alcohol exposure in utero, with cigarettes exposure in utero, and also some of my research suggests that maybe even severity with secondhand smoke exposure. And it's amazing, but we don't coach parents about don't smoke in this child's face. It's actually not healthy for the brain. There may be a propensity for this child to become a user of drugs because of their impulsive nature, and then you're basically priming the brain with smoke-filled room. And so there's a theory there that we should make sure we absolutely discuss as part of your treatment plan, that you should not be smoking in general, but certainly not in front of your child for multiple reasons, not just breathing. So I think exposures are sometimes just sort of glazed over, but they're important, especially in this pathway. And we have special educators in the room, and we have school psychologists in the room, reading, writing, and math. So I don't think it's rocket science to diagnose ADHD. I think you can tell when a kid is hyper. I think you can tell when they're inattentive. But what the specialist's job is that we know that ADHD rarely occurs alone. So our jobs are to pick up the things that get missed, while the teacher or maybe annoyed with the misbehavior aspect, you are to pick up the 30% that will come with a reading delay, the 30% that they're misbehaving because they don't understand, because they can't focus, because they can't sustain attention. That is your role, because the ADHD, typically, if it presents in a severe way, is not that hard to miss. But I think it's the reading, the writing, the math, the comprehensive academic testing, that's where you're going to find that this is a disorder that rarely occurs alone. In fact, you might be missing it if you haven't found anything. That's pretty rare. So why do I spend my time studying ADHD, and why do I spend my time in the preschool clinic? There's risks in many domains, and this is before the child even started kindergarten and first grade. Academic readiness skills put the child at risk. There's physical risk. These kids are impulsive. They're getting in more accidents. There's lots of literature on that. Later on in life, we also know if it's untreated, there's a high risk of substance use and many, many other physical risks. High risk for comorbidity. I just said ODD, CD, 60 to 80% of the time these children will have oppositional defiant disorder, disruptive behavior disorder, anxiety disorders, depression, substance use risk, and all the meantime, some people may be caught up in their misbehavior, and you realize that this is a complex phenomenon that should be comprehensively addressed. Okay, so again, I get older child psychiatrists, well, even child psychiatrists who are my colleagues who see older children and say, why do you bother with the little ones? And I say, you're missing the boat. That's why I have to bother you. You have to start early. So we have multiple researchers in the United States who have already followed these kids into certain ages. And the stability, when comprehensively diagnosed, the ADHD stability 3-year rates about 80% into school age. So if you actually accurately diagnose it, then it's pretty much going to continue. If you kind of just did a 5-second visit or a 5-minute visit, then maybe you didn't get the right diagnosis, and so it may or may not continue. But when accurately diagnosed, it is a very stable diagnosis into school age. What about 6-year stability? Still high, especially in moderate to severe cases. Some of the research I did in a community sample suggests that it's much harder to do in 3 to 4-year-olds, where the frontal lobe is developing rapidly, and so you may, if you can, try to wait till 4 to 5, because there's something about the diagnosis that's even more reliable and stable at 4 to 5 than from 3 to 4. And it sounds like just a small, but it's a huge developmental milestone. So similarly, preschool disruptive disorders, which include oppositional defiant disorder and conduct disorder, I hate to pick on the boys, but it occurs more in boys than in girls. The prevalence is 4 to 17%. 2-year stability, again, pretty high, 50 to 75%. Conduct disorder in preschool age kids, again, 3 times higher in boys than girls. Prevalence of 0 to 7%, a little more rare. 2-year stability, about 50%. Okay, so what does it occur with? I would say your heavy hitter is oppositional defiant disorder. Pretty much 60 to 80% of the time. These are the kids that it just doesn't explain it to say just ADHD. They're disruptive, they're blaming, parents will talk about stealing. And of course, this combination has a worse prognosis. And part of your psychoeducation, as someone pointed out, parents need to know a lot about what's happening, but you have to frame it in a hopeful way, but this is definitely a more severe combination. It's harder to treat the combination. What about things that go in favor? Let's say you do have, is it doomsday if your child gets diagnosed with ADHD at such a young age? No. In fact, it could be helpful. It could help give them the tools to make a better special education plan. So some things that are known in the literature to actually improve the prognosis of ADHD include higher parental education. We can't change that, but it just shows that there are factors in place that you might think of when you're assessing the family, what might change the prognosis of the diagnosis. So higher parental education, a lack of parental ADHD, or well-managed symptoms. I mean, it's very hard if you have a 3-year-old who's disorganized and running around, and then you're asking mom, who's also disorganized, how to help the child. One of the hardest conversations I have to have is telling the mom, you've come and you brought your child to me, but part of the reason and the way that this child's going to get better is for you to get better. You have to get some control over your symptoms, or how are we going to have him or her learn when you're unable to help? Because you're also forgetting where's his backpack, where's his book, where's his homework, and then the kid is, it's tough, but it is a hard conversation and it's worth having. Of course, the prognosis is better with better overall infant health, higher child cognitive ability, increased language skills, and that's probably not surprising, family stability, increased family organization, coping skills, strategies. Okay, so what has the most support right now for treatment of ADHD in preschoolers? It's behavioral parent training. It has the most support. So you might look at multiple people who have written about behavioral parent training, and there's nuanced ways to, Barkley is one of the lead authors that you guys might know. The other therapies are effective. They have less evidence in ADHD. They may have more evidence in disruptive behavior. But parent-child interaction is one of my favorites because it involves both the parent and the child, and we can talk about that in a minute. There's also written up in the literature positive parenting program and incredible years. I don't care what you try, just try something that has some evidence that involves non-pharmacologic intervention first. Pick your flavor of psychotherapy of the day, but make sure you try because it is worthwhile, and a lot of these have excellent outcomes. Psychopharm is the second treatment of choice, of course, after you've failed. And I usually say 1 or 2. At least try, and try means you actually stuck with it. You didn't just go to one half of an office visit for the therapy, but that you actually tried. And psychopharm, not unlike adolescents, stimulants are the evidence-based treatment of ADHD. However, in kids, you have to watch it for multiple reasons because there's some side effect issues, and we have other national multi-site studies to guide us when we do use medication in kids. And we should use those studies because we don't have a lot. Okay, so what is it that this therapy is targeting? Why does it supposedly help? I don't think this is necessarily brilliant, but it's a short explanation of why it works. So behavioral parent training specifically educates parents on the disorder, like someone said in the audience very astutely. You have to. That's part of the treatment. Mm-hmm. It's part of the treatment. It's not even sort of an option. If you are not educating the parent, you're not going to make progress with the kid. It's that straightforward. So you have to tell the parents, what is the prognosis? What is this disorder? What does it cause? What do we think it's caused by? What do we think is going to happen? How can we stay hopeful? How can you manage? This specific therapy is thought to help because one key issue is found over and over, and that is the parental sense of self-competence. So they do many psychotherapy studies, and they take 100 measures. And one of the measures that often comes up is that when the parent report of self-esteem and self-competence, their ability to parent this kid goes up, guess what? You start to see improvements also in the child. Reduces punishment behaviors because you can get into a cyclical pattern of parenting where you just focus on the negative and the misbehaviors of this child, and it helps them actually learn how to reduce punishment behaviors and focus on the positive by increasing positive reinforcement behaviors. And also it also encourages how to support discipline consistency in home, school, and public. And that, again, I don't think that's necessarily hard to understand as mental health professionals, but you'd be surprised how what happens at school stays at school, the rules at home are different, the next day it's different, well today it's vacation and tomorrow you can sleep till 11. It's not good for the child that has ADHD. There's got to be structure and routine. Imagine if you feel internally disorganized and then your life is also completely disorganized. It doesn't really promote wellness. So, of course, it doesn't occur in a vacuum that it just, if you send your referral off to parent training, it's going to work. What has to occur? It's the same thing we just went through. Adult parents or teachers have to be involved. They have to be on board with the plan. If they're not involved with the plan, it generally doesn't work. So you'll see some of these themes in child psychiatry come up over and over. 15 studies later, we're finding out, yes, parents have to be involved. It's the same thing. Training occurs in specific context of impairment. This is hard. we're not quite at the point where we think if I went to all the preschools and gave a specific therapy, that effect would translate to the home. We're not quite there yet. So, I do work in the lab, and I help you with your ADHD. We're not quite sure that that'll specifically address all your problems at school, in the school setting, because these are context-dependent symptoms. And so it turns out some of the best efficacy rates are shown when the therapy is done in the worst problem context and translates. So in other words, if the school is the worst part of this person's misbehaviors and or inability to focus, giving that therapy specifically to the teacher and the school setting may actually translate to the school setting. So contextual learners, and that's hard to get right. Also, you have to know what you're dealing with. So ADHD is broad. So there's attention, there's impulsivity, there's hyperactivity, there's multiple domains. What are you treating? And you have to document, what are you treating? Are you treating the inattention? Are you treating impulsivity? So if you actually focus on your target symptoms, then you might actually know if the therapy is making progress, or if you're making progress with that child. Also, we have come a long way in understanding ADHD, and it's better to think of it as a chronic disorder, not just, we'll just give you help this week or this school year, and then you'll be done. Got to think of it as a neurodevelopmental disorder, as it's changed also in the section in DSM-4 to 5, it changed chapters to a neurodevelopmental disorder, and appropriately so. And of course, when it's available, I don't know if therapies for younger kids are available in your countries. We might talk about that at the end, but it is still hard, even in a university town, to find therapy. I mean, they're full. There's a wait list of six months in some cases. And so people just give up. I mean, this takes a lot of patience. And sometimes parents will say, I'm not waiting 6 months. I mean, we've got to have a solution now. Okay, so we may or may not go through all of this on parent-child interaction therapy, but in general, I want you to know that it's one of the most evidence-based treatments for disruptive behavior ever. And so much so that basically people have tried to tailor it to every disorder. Now you can hear about PCIT for anxiety, PCIT for autism, PCIT for... And part of the reason I think it works is that Sheila Iberg, who conceptualized it years ago, basically she had some theoretical reasons that she thinks that this therapy would work. First of all, it's dyadic, implicitly that the parent and child are both involved. They both show up to the therapy. The therapy's done in a two-way mirror room. There's a telephone piece in the ear of the parent while the doctor or clinician is coaching live in session, so that you don't just hand somebody some principles and then they go home and try to figure things out. They actually learn in the lab. So you give them tasks to do together as a parent and child, and while they are interacting, the therapist is actually talking to the parent through a phone piece. Okay, now try this, now try this, now try. So basically, by the time they go home, they've mastered a certain amount of behavioral principles. Ideally, I mean, this is not the real world, but ideally, if you didn't have any limits to research time or funding, the PCIT works because it's performance-based. You don't get to pass the first level until you've shown competency. And so if anything that you say things will generally work if you say you can't pass until it works. So you go to phase 1, but you don't go to phase 2 until you're actually competent. Now, it's the average length of this training is 13 sessions of 1 hour weekly, and you only get 5 minutes of homework, but you'd be surprised sometimes parents don't finish that even. The 5 minutes of homework is basically specifically play. Play with your kids. Don't look at the TV. Don't look at the iPhone. Just play and interact with them as if they were the only things in the world. Full attention, so that this kid actually wants to behave and wants to so it's building on a relationship, and then the second phase is discipline. And of course, you have to go to the official therapy center to get certified, so there's some validity, reliability, and standardization of the model. Okay, so I told you a little bit about how they attend together, they attend weekly, they review homework at the beginning, and you don't get to graduate till the next phase until you graduate from the first phase. So of course it works. So how did she coin this bump? So it's based on, PCIT is based on a developmental theory of Diana Baumright. And the idea is that we're moving the parent towards becoming more authoritative. And for those of you with, you've heard this 100 times, these parenting styles have been used in the literature over and over. Authoritative parenting is a combination of both high responsiveness and firm limit setting. So parents are thought to be much more ideal when they can do both. And it is very hard to get some parents to do both. They might be very permissive, and they're warm, and they're fuzzy parents, but they'll let their child do anything, and that's not, so they need to be educated on that, and also part of this therapy is learning how to progress through. And so if you're more visual, which I am, if this were a graph, you were trying to maybe not. Clicker. Oh, you've told it down. Okay, so if this is acceptance, responsiveness, and warmth, and this is demand or control, this is where we kind of want you to be, both high, warm, acceptance, and high, firm, demand, control. This is one of the, you're going to do this because I told you to do this. That doesn't go over so well. This permissive, we've heard about it again in the literature. I'm warm, I'm fuzzy, do whatever you want. Okay? And there's the disengaged, uninvolved parent. But basically, the therapy is aiming to kind of push the parent into this quadrant. Okay, and so you guys, a quick review of those, you know that. So we just went through that. Okay, so what do you do? What do you do when you get to the point where your therapist is calling and saying, haha, this is not working. There's no way this child, they can't sit still for 5 seconds. How are they going to participate in my therapy? Well, we try to say that we reserve that. Even for 4, 5, 6-year-olds, we still try to reserve medication for the last resort. I will tell you a personal story. One of the kids that I had to put on a medication was a 3-year-old who was exposed to heroin in utero. Well, so I sent her to the therapist, and I got a call. Dr. Tandon, really? You thought she would participate? I mean, she hasn't stopped moving. First of all, we can't find her. When she gets to the clinic, she's motor driven. She can't stop moving. So how can she participate in learning? That's her job as a child, is to learn from her environment, but she can't because she is moving nonstop. So she came to the specialty clinic, and we looked and we tried therapy, and I talked to her about anything that had failed or tried in their work so far. It's just not happening. So we do have exceptions to the rule where we kind of resort to a small dose of medication so that we could at least gain from the therapy, and then maybe we back off the medication. So moderate to severe dysfunction, I would say this child's pretty severe. She was off the charts, actually. We try to say that you've diagnosed, but not only that they're moderate to severe, so what does that really mean? Well, we extrapolated that from the PAT study, which is a preschool ADHD treatment study that went on in the United States in multiple sites, and it's one of the few randomized controlled trials that was done in this young age, so that's what we gain our ideas from on what should we do when we get to the point of medication. So if the signs and symptoms persist at least 6 to 9 months, if the actual problems are occurring in at least 2 settings, say preschool, daycare, neighbor's house, grandma's house, mom's house, failure of non-pharmacologic treatments and behavioral therapies, then we may consider it. But again, I would do it very cautiously. I would do it with a person who sees more kids this age. And the American Academy of Pediatrics says that we can use stimulants down to age 4. We don't want to, we don't like to, but we can. The methylphenidate is used as it is in older kids, but it is still off-label for this age group, but it happens to be this was the medicine used in the PAT study, so at least we know how some of the kids responded. Amphetamine salts, Adderall, this may be not so interesting to the people that are not in medicine, but interestingly, we still don't have a lot of data guiding us in this age group, so it becomes very hard when you're that when you're getting into the territory of medication. So I've been telling you about the PAD study, the Preschool ADHD Treatment Study in the United States, 165 kids aged 3 to 5, basically they figured out what happens to them after a month of being on a stimulant. And also 1 year out, what do they look like? What kind of side effects do they have? So they had to all fail therapy just to enroll in this study. They had to fail therapy. So you're already getting moderate to severe kids. And they failed 10 weeks of a trial of therapy. So the effect sizes were high, so 0.4 to 0.8 for the use of the medication. And it's tolerated, it turns out, for these kids in this study, but they're sensitive to the side effects. They get irritable, they lose their appetite, there's problems with growth. So these, again, have to be used carefully in this age group, but since I have a biased sample in my clinic, I have to go there sometimes. You have to use minimal amounts of medication, and you have to monitor them, and you have to get an EKG if they have any kind of cardiac history or concern. You have to obviously educate the parents a lot because this is uncharted territory. And of course, you want to keep measuring as you go along so that the moment that things are a little bit better, you could maybe do a trial off as soon as you can. You want to use objective measures, not just mom had a bad day and so she's over-reporting today, but that if you can track objective measures, you can know what dose worked and what did not work. Okay, so non-stimulants are not FDA approved by our drug agency either, but we do use them. Some kids don't tolerate stimulant trials at all, and we have to get to 10X and other medicines. Since we don't have psychiatrists in the office, I'm not going to sort of belabor the point, but there are a number of medications used in over age 6, but this is more to tell you that we don't have a lot of data to support us in what to do when we have a young kid with moderate to severe ADHD. What do we do with the psychotropics? I mean, we have mechanisms of actions. We know how these medicines work in older kids, but we have to extrapolate from that, and we have to be careful because older kids and little kids are not the same. Okay, well, people ask very often in forums, and maybe not this one, but what about diet? Can I just change the diet? This kid will get better? So my general theory is there are levels of support in medicine and in practice. And I can't tell you that it will go away if you just stop giving your kid sugar, right? Because it's a highly heritable, genetically laden disorder. So it's unlikely that just stopping sugar will just change this person's prognosis. However, a good, healthy diet is great for every brain and for overall health. So if it's good for your overall health, it's probably better for your overall prognosis. What about nutritional supplements? What if I just give a bunch of vitamin D? Or what about vitamin A? Or whatever our favorite vitamin of the month is in science, right? Case study level support. I mean, is it good to have all of your nutrients on board? Of course. Could it only help your brain? Yes. But it's not going to change the prognosis of the ADHD necessarily. What about just if the child alone comes for therapy? Will that help the ADHD? Well, there's a reason the first slide said parent behavior training. It's actually the parents that have the highest level of evidence for change. So bringing the kid alone, okay. But the question is, if you just train the child directly, are you really getting anything above and beyond reinforcement? If you just use basic reinforcement principles, would that be the same as teaching the kid self-regulation, or are we gaining anything by just having a kid in the office in therapy for ADHD?
Just have 10 more minutes.
Okay.
They told me to tell you.
Okay, perfect.
To open up this.
No problem. So 10 more minutes. That's too good. We're almost done here. Okay, so executive function, cognitive flexibility. What do we mean? Interventions that target executive function. What is executive? So you'll hear executive function intertwined with the word ADHD very often. It's your ability to have a flexible cognition. It's your ability to retain certain amounts of information a certain amount of time in your memory. It's your ability to inhibit or self-regulate or control. So there have been a number of emerging studies on whether using a computer program to help retrain your brain will change your ADHD. Well, there is limited evidence for this right now because it may help, But the question is, does it transfer? So in other words, if I play this game and it helps me think while I'm playing the game, does it transfer to my math test? Does it transfer to my ability to sustain attention and stop wiggling at church? That's questionable. So we're working on that, but at least this is a non-medication way of trying to make use of these computer games that everyone is so excited about. Maybe we can find something that will help people find a way to work on their working memory. But right now we're not there. What about exercise? Exercise has tremendous evidence to be helpful. So if there's anything that is not medicine and not therapy, I always say, absolutely, please have your kid exercise, especially these little kids. Sometimes they misbehave, and then they lose their recess. And I write a note to the teacher, please don't. This is the wrong treatment for this kid. Do not take recess away from this kid with ADHD. It's very circular. It won't help, and it won't help the child. I've actually written that on a prescription pad. Please stop doing this. Please stop doing this. Find another version of removal, but don't remove recess. This kid has to run around. So there's data on aerobic exercise. There's data on mindfulness, but imagine a 3, 4, 5, 6-year-old learning mindfulness. We're not quite there. Okay, and a kid with ADHD of all things. So this is tough. It is in older children, so mindfulness is a real trendy topic in the United States at least. Okay, so an ODD-CD in this age group, not a very similar pattern, algorithm of treatment. First, psychotherapy, usually behavioral parent training. If these fail, there's some stimulants and or 10x and or atypical psychotics, antipsychotics at times that are used. We're trying not to, but it happens. Okay, let's see if we made you snooze, and we're on our last 2 slides here. An accurately diagnosed preschooler with ADHD will no longer meet criteria for ADHD once upon school entry. You can shout it out. True or false? Good. Of all available treatments, the first line of treatment for a preschooler with ADHD is medication. False. Of all available treatments, first line of treatment for a preschooler with ODD or CD is medication. PCIT, which is parent-child interaction therapy, reinforces the authoritarian style of parenting. False. What does it reinforce? What are they trying to get to? Yes. There is no place for exercise. There is no place for exercise or computer training to help executive function in preschoolers. What is the evidence? Yeah, exactly. Okay, so this is my book. It's available on Amazon and other things. I wrote it because as a person who's running a preschool specialized clinic, over and over the parents call the front desk and say, what do I tell my kid? And I go to the grocery store and I see Dora goes to the dentist and Dora da-da-da-da, and Dora sees her pediatrician. But when you have a kid going to a mental health professional, it's almost like, what do I say? What is it going to be like? Do you wear a white coat? Do you give me shots? Do you give me vaccinations? So to destigmatize that, we have a children's book. And we offer that, and we have it in our lobby. Anyway, this kid in this book, in this first book, has ADHD and tics and does some interesting things at school. And then he goes to the mental health clinic, and it's not so bad as he thought. And, we try to just make it less scary. Okay, we have a number of references, and I'm happy to give you even more if there's some aspect of this you want to know about. Since it's something I study, I can tell you more about any of these references. All right, you've been very attentive, and no pun intended. So thank you.
So interesting.
Yeah.
Actually, I think we have 5 more minutes, but I think it's so interesting, Dr.
Thank
Tandon.
you. Thank you.
And if you have any questions, etc., would be. I have a question, but please
Don't be shy.
don't be shy. I love the cartoon. You were in the cartoon.
Yeah. Look. Yeah. Oh, just mind-numbing, huh?
Actually, I think you covered them, but they are.
Can I know why always the rate is more in boys than girls?
It's a great question, and I don't know that we know the exact answer, other than it genetically runs.
Every time they ask the same. Boys are more.
They are, and we may find out as genetics is blossoming in psychiatry, we may find out more about why. I don't think they've pinned it down.
Even when parents generally they say boys means it's too noisy, and girls is they will always listen and do whatever we ask them to do, they will do it.
Mhm.
So it's always like that.
Mhm.
So maybe the way the parents tell, generally if they talk in among friends
Mhm.
also, they use the
Mhm.
same words.
Mhm.
Boys are too troublesome, but girls means okay.
Mhm.
So it's like that, but now you say even the ADHD and the OTD, everything is more in boys than in girls.
Mhm. Autism too. Lots of psychiatric illnesses are more frequent in boys.
Any specific reason?
We don't know yet, but like I said, I think genetic studies are about to tell us more about whether there's a Y chromosome or a male effect. The other thing about what you just said is really critical, real quickly. When we stereotype the boys on the girls, so the girls are quiet and they're playing, girls get missed all the time for inattentive type ADHD. Why? Because it's not very problematic. If you're the teacher, it's not very disruptive when somebody's spacing out. That doesn't really bother you, right? But that person can have some tremendous academic difficulties because they're inattentive ADHD and they're not causing really a problem, so to speak, but it can be very life-changing for them to not get treated. Yeah.
Thank you very much. This
Sure.
was groundbreaking because being really, working in the mental health field in Greece, listening about ADHD in preschool age is something we don't hear about. Very interesting. Can I ask you, would the PCIT work with adolescents?
It's generally not used after 6 to 8 or so. Now, I think it could work, but the idea is that it's dyadic, and so it's implicitly dyadic because of the age. So, we kind of say that a kid doesn't exist alone. A little kid definitely doesn't exist alone. So that's why the therapy is dyadic. Now, by the time you get to 14, 15, 16, you know how kids feel about their parents. So they are able to supposedly function on their own, and they should be able to attend the therapy alone. So PCIT, that doesn't mean it couldn't. But in general, we've seen maybe max 8, and then people stop offering it. It's not really validated, to be fair. It's not validated beyond 8 to 10. Now, other studies have tried to extend their age group and see if it will help. And right now, it's just not, they haven't given the sort of the manualized version of how to do it in 14 effectively. How would it work? But in the 3, 4, 5-year-olds, it's great because it's not heavily language dependent. It can be, but it is actually tailored for that age. When she first validated the therapy, it was for 3, 4, 5-year-olds with conduct symptoms. So it's stayed that way. Yeah. But that's something ripe and ready to try. If we could make it appropriate for the age, why not?
Is there a correlation between intelligence?
Can you talk to a microphone because
You're soft-spoken a little bit, yeah.
Is there a correlation between intelligence and ADHD? Because the reason why I'm asking this is, there was this boy, not a preschooler, who came and I had tested the intelligence and he scored 140 on WISC, Wechsler's But then he has, so I was wondering, like somebody with ADHD will not be able to sit still for 2 hours and do the task. And he did it. I just want to know.
It's a great question, and it's not always correlated. You can go completely awry by trying to predict intelligence. In fact, one of the first things parents say to me is, "My kid's not dumb. He's just hyper." I said, "Of course your kid's not dumb." They're bombarded. Their brains are bombarded with stimuli, right? And if you can get them to focus and take a test, it's not true that they're always going to show below average scores.
No, what stumped me was he sat through the test without any distraction. He took the test. And
Yeah.
I couldn't find behaviorally observing, there was no attention issues there.
So multiple reasons for that, and that's probably a talk on its own. But when you engage somebody at a specific level on something they may or may not like, and once they have started the attention, there are individual traits that can pick up that this person can do it. Or it's the same reason that people will say to you, oh, he can't focus in school, but if you play his favorite video game, he'll sit there for 4 hours. You know, why is it that some things can sustain some kids' attention and same kid with ADHD cannot take the test at all? So it's hard because we try to develop algorithms for treatment, but really we need to think about personalized medicine. Because one kid can finish that test.
Okay.
The other kid without accommodations cannot finish the test and then will be called, oh, you're, behind. Not true. So, I mean, we apply Gardner's intelligences, think about many ways to test or examine a kid, extended time to take the test. What else do? We put them on the front of the class so that they can't look at all the 100 things that are bombarding their stimuli. So many things. So it's hard to, in treatment of a child with ADHD, they're very heterogeneous. And one kid can score 140 IQ, one kid will score 90, 80. It really depends on the kid. And
Yeah, it was not the IQ score itself that actually made me think. What struck me was, as I was saying,
Yeah.
he sat through
He
without
sat through it.
distraction.
Sure. It can happen. It's not
Yeah.
impossible. It's a matter of his brother may not be able to do the same thing with ADHD. We have kids with sibling pairs in the research study, and then also at WashU, we see that 3 brothers have 3 completely different flavors of ADHD. Yeah, it's very interesting.
Well, thank you.
Sure. Okay, I think we're running over
Okay.
time, so thank you so much.
Before you close, and it was very, very interesting, the mindfulness. you
Yes.
talked about.
Yeah.
Because now in the States, everybody talks about mindfulness. I was ready to. go
Sure.
to,
Oh, yeah.
especially California, it's.
Highly funded.
Sorry. About mindfulness. Are you aware about mindfulness? Would you like how this would you like some water?
I'm good, thank you.
How this helps the ADHD children, mindfulness, meditation, relaxation. Yes, give us some,
Yeah, that's me. I don't know. That bottle? I don't know whose that is. Yeah.
No,
That's okay.
not that bottle, the big one.
So, he was just trying. So, I don't know yet, but I think part of the idea would be the mechanism is probably learning self-regulation, which these kids may inherently lack. However, in the age group I was talking about, preschoolers, this is very hard because I will see it when I believe it, but I think teaching self-regulation is harder with this age, but there are ways to do it developmentally. So the idea being, let's say even if it's a calming technique, instead of thinking of it like you would in yoga or mindfulness, you take yourself to a far-off land and deep breathe, the 3-year-old's going to laugh at you. First of all, he can't sit there. But second of all, if you make it age appropriate, which is what I think will need to happen, okay, you get to pick what is your place that makes you calm. Of course, I asked this of a 3-year-old, and they said, the toy store. I said, no, so if you can get into the brain of that 3 and 4-year-old and say, what makes you calm? Is it squeezing your teddy bear? Is it thinking of a turtle? They have all these techniques they use in the little kids. So pretend you're a turtle and you went into your shell. And you have to literally help them create their own self-regulation. And now just relax and take a deep breath. So the mindfulness is it's in iterations in older kids. So I think for the little kids, it's going to be very hard. If someone can be developmentally savvy and make it work, I think it could be helpful. Yeah. So I think the idea is probably one mechanism that I cut right off the bat is self-regulation. It's teaching self-regulation.
Self-regulation, that's very important.
It may work on executive function. It may work on...
Can you give us some exercises, for example, of mindfulness, 1 or 2, briefly?
I can't because it's not my specialty.
Okay,
And because
okay.
of these little kids, I haven't used it very much. I can tell you that we call it coping skills. When you're,
Okay.
a lot of these kids have
Okay.
an impulsive
Coping
temper,
skills,
and we call it coping. We don't call it mindfulness because it's hard to get them into their own mind at this age. So I haven't gotten there. But when these kids, when the parents complain, oh, this person has such a high impulsive anger, as soon as they don't get their toy, they hit the next kid. This is what we hear in the 4-year-olds. We teach them coping skills by saying things like, okay, when you feel that anger, what can you do? And some kids will say, I turn into a turtle. I put my head into my body, and I think about it for a second. And then, or some people will say, I make myself feel like spaghetti, and I just wiggle, and then when I calm down, I stop wiggling. So there's these very sort of useful analogies that people have used in their therapies for little kids, but you have to make it kid-friendly, otherwise you tell them, oh, deep breathe and go into that calm place, and they're like,
Yeah, of course.
yeah, right.
Yeah, of course. What are you talking about?
Right. Yeah. So
So very, very interesting. Thank you so much.
You're
It was
welcome.
fantastic.
and thanks for inviting me and having me here in Greece. I'm having
Yes,
a nice
enjoy
time.
the rest of your stay. And now they will open this and they will make it a big room. So we have to move and come back